So let's start in the records. The most common type of case that we see is dentate, single arch dentate, and often double arch dentate. The records are very similar for both. And as mentioned, the records are also very straightforward for chrome guided smile. In fact, 1, 2, 3, a series of photos, very standard photographs, upper and lower cast in a bite, and a CT scan. That's all that is needed for to start a dentate case. So we'll go through the dentate first. So as you can see, this is the collection of records for single arch or even for a double arch chrome case. On the left are the models, upper and lower casts, bite registration. This is from a digital, actually this is not a digital, this is a conventional impression that's been digitized, poured up and digitized. CT scan that captured both upper and lower arches with space between. With the dentate, you always have the patient open. And then the photographs, full face, full smile. We'd like to see a little bit more of an exaggerated smile than this gentleman. But often that's kind of tricky with these cases. A lot of these patients have, have years of stress with their dentition. And so sometimes it's tough to smile. But we like to have a full face smile, and I'll explain why in just a minute. And then the photographs retracted, center, left, and right. So we can see how the teeth come together. And we'll go through a little bit more of that in the coming slides. And we could just say, those are the records, have a nice afternoon, all done. Records for a dentate case. But the fact is, over the past couple of years, even the few years, at least things are getting a little better now, but for a time it was 7 cases. Now it's maybe 5 or 6 cases out of 10. The records come in and the red light goes, which means we either have to make a phone call or have some kind of discussion about the particular records. Either something is missing or additional records need to be captured. Most of the records, again, they're straightforward, but there are questions that need to be answered and just some missing items. So that's why today's program will be so helpful for the doctor and the staff. So the photographs. Very simple, straightforward photographs. We do recommend an SLR camera, but frankly, cell phone pics are very high quality these days. I would recommend that even if it's a cell phone, put the camera right in the center of the nose and take the picture at that level. We really like to see the plane of occlusion as we are looking at the center of the face. Full face, full smile. Try to get your patient to have an exaggerated smile. And then left, right, and retracted photos. We always want these in occlusion because we want to see how the teeth come together when we are analyzing the models on the articulator. So it's it's a verification that we had the case articulated correctly. We also, on a lot of cases, would also like this photograph with lips at rest. That may be patient by patient with how much tooth display there is and how much aesthetic changes we're going to have. But then also on the right, if a patient is severe class 3, severe class 2, take profile photographs. Those can help considerably with the tooth setup. The full face, full smile photograph, we use this for smile simulation. In fact, every case that comes through our laboratory, we perform a smile simulation. We do it with this software called Preview. We have been using smile simulation softwares for years, many years. This is by far the best software we have ever used. It's a very simple process. In fact, they boast after they train you that you could do a smile simulation in about 1.5 minutes, 2 minutes, a really nice quality photo. And that patients just love. I'll show you some examples of it. They love doing demos. Call them. It's this. We're not associated. We're associated with them, but this isn't a. This is basically a promotion for them. They're actually a wonderful company with an easy to use software. So Preview. So we take the Preview software and we essentially take the patient's STL files, the files from the digital impressions or the digitized models, and we superimpose the patient's face over the models, over the 3D models. So a 2D face over the models. And then we use a smile simulation to perform the setup. So normally there's about 4 more images here, but one of them will be the simulation that we did with preview. So we set the teeth, we set them in an ideal position behind the lips according to the STL models, and really do a nice job of putting teeth in the right place physiologically and aesthetically. And from this is what we use to do the setup, and then eventually make the chrome prosthetic. So you can see this case has come full circle from the beginning here to the end, and the setup obviously is very similar to the restoration at surgery. So we really try to make a one-to-one smile simulation through to the prosthetic. And we do that through this preview system. Preview, we partnered with them a couple years ago, and they were nice enough to take STL files of denture teeth that we use to set, real denture teeth that we export as STLs to fabricate prosthetics. And they took their beautiful natural smiles and they morphed them in the shape of our denture teeth. So when we set a tooth, for instance, when we set a triangular mold in the software, it's the same as the smile. So is it a one-to-one? No, it's not. But it's pretty close. It's definitely an A, especially in the patient's eyes. It's an A, A to A plus. So we use those smiles. We make these smiles every day for patients all around the country. Patients love them. We have a lot of doctors who actually have the software and use the software on patients throughout the day. So these are just some examples. You can imagine these patients have been through basically dental trauma for many, many years. They see a preview smile that's part of our records system, and they are more empowered to make a decision. They know what they're going to look like. And these smiles are brilliant. If you have a 60-inch monitor in your patient consultation room, these smiles still look magnificent. You really will be shocked. So you can imagine all these patients we've shown you what their reaction must be when they see them. One thing about photographs is we want very good photos to do a smile simulation. So obviously we want to see a smile, want to see teeth, I want to see the eyes open. Try not to like the one on the right. Try to bring the camera a little bit closer, because by the time you zoom in on this gentleman, it'll be fuzzy. It'll be a little bit out of focus. The patient on the left, I have him stand up. He's kind of leaning back in the chair. Actually, I think he's leaning back in a chair against a wall. Patient on the right, a little too much flash, a little too much washout. I mean, one of our goals is to really wow the patient with this record, with this smile. So, here's a gentleman. They went through several different photographs, and we'll take them all. We can pick which ones are the best, but you can pick them too. And so it went through a whole smile of this guy's just being happier and happier and happier. And then finally, the happiest he can be right there. Take both of those pictures and upload them with the case. This gentleman's not happy, but I know that you can make him happier for the photograph and certainly through the surgery. So work hard to take, please work hard to take a nice photograph. And then the other set of series, as already mentioned, teeth in occlusion. And we take these images, we put them on a big screen here at our stations with your models in hand in the articulator, and we confirm that the case is articulated properly. Articulation, occlusion is just one of the most important things that we do here so that you have a successful surgery, so that you have a good bite experience. And part of that is just really these simple photographs, sending them in with a case. So we magnify them, and we literally look back and forth from the screen to the models and make sure that we're articulated right. One thing important about the casts, either the casts or the digital impressions or the impressions that you send in, is that they involve all of the land areas. You want to capture, imagine you're taking an impression for a denture, right? Immediate denture, because essentially you are. Most of these cases, the doctors order a backup denture just in case things don't go perfectly during the surgery. So you want the vibrating line, the full roll, if it's an analog impression. If it's a digital impression, sometimes you cannot capture all the land areas down into the vestibule, but you can at least capture all of the labial, lingual tissue, capture the palate, etc. In fact, today, most of the cases that come in for Chrome are from digital impressions. Doctors have I've just found the value in digital for speed, for accuracy, an excellent way of capturing a bite with digital impressions. We work with all the systems. There's more out there on the market. We work with all of them. And the reason, again, the reason you want to capture the full, I think these are videos. The reason you want to capture the entire scope, all the land areas is because the first step of every surgery is the pin guide. The pin guide is what rests on the teeth or tissue, but it also, on many cases, goes deep into the vestibule if there is significant bone reduction. As you can see on the left, that case is going to require a lot of bone reduction. The pin guide is going to seat deeply, and therefore we don't want to guess where the tissue is, where the support for that pin guide is. So please try to capture a full land area impression. And make sure that the impressions are very accurate. You know, some pulls, some drags, some bubbles, some voids. You know, some of those things can be overcome. But if there is distortion, or if, you know, a case like this, please retake. It's good to catch at the office before it comes into the laboratory, because we'll definitely give you a call. You know, if it's not perfect, we want your success to be part of good record taking. All right, so those are photos and models, and then the bites, vertical measurement, this type of thing. So we get all kinds of, we get a lot of the standard bites. Most of the cases come in have a centric occlusion bite, which is perfect. It's fine. You know, most of these cases, a patient is overclosed, and we have to open on the articulator and either go forward with production, or if the vertical opening is more than 3, maybe 4 millimeters, then we have a little device that we send you to confirm the opening. You know, simply just because the arc of closure of an articulator cannot be transferred always to the mouth. So centric is the most common. We do get some centric relation. I'm sorry, centric occlusion is most common. Centric relation we do receive. And then we do receive occasionally some neuromuscular bites. Might make the argument that a neuromuscular bite is the best bite for these cases. Putting a patient in the most comfortable, relaxed position might be the most advantageous, the most accurate. But we accept different bites, of course, and we do our analysis accordingly based on the bite that you send in. So for dentate, photos, cast, bite registration, and then finally the CT scan. So a CT scan for a dentate patient is always open out of occlusion. I know that there are other companies out there that make surgical guides, full arch surgical guides, and they want the bite in occlusion. Never really understood that because we always use the stone casts or optical scans to articulate, to open, to do the concrete records for bite registration, not the cone beam. The cone beam is just for bone, tooth, to make the surgical guide and to design the guide, that's all. So when you capture for whether it's single arch or double arch, we want the full scope of the arch of interest or both arches. So the green line is the maxilla. We would like to see a CT scan of the patient from the sinus, middle of the sinus, down to the opposing teeth, and then on the mandibular down from the chin at least you know, below the mental foramen, but down to the chin, and then also including the upper teeth. Then we know we have the full range of bone that we need to plan the case. And every cone beam out there has a mechanism for exporting raw DICOM. Normally what you'll see, well, what we want you to see is a folder full of DCM files. Sometimes it's 200, sometimes it's 800. Our upload page limits at 400 megabytes. Now, normally when a folder is zipped, it's under 400. If you find that it's over 400 megabytes, the best thing suggest doing is contacting the Cone Bean company and asking them to export a smaller, not FOV, but a smaller voxel, so that you're at maybe 0.4, probably 0.4 thickness between the slices, and that will minimize down to at least 200 to 300 file numbers. And you zip those into a folder, and you submit those along with your records. That's the DICOM. So let's say the records have been collected, they've been sent into us, and now we analyze them. We have veteran CDTs who work on these casts. We have a couple of dentists whose full-time job is analyzing casts, doing these case workups. And I think we do a very good job with this. These are all very challenging cases, just about every single one of them. We go through a rigorous analysis of the records, analyzing the smile, the bites, the models, the vertical needed for prosthetics, reverse smile lines, gummy smiles, just the whole range of things that we need to analyze for full arch. We go through that with every single case. And if everything is accepted, the models are good, the records are all perfect, that night you would get an email. And in that email, there would be a link to set up your online meeting online. If we find that the records are not perfect and good to go, then we contact you and we have a discussion and just see which direction we're going to go with either attaining more records or moving forward. Depends on what the discussion needs to be. So when we are analyzing the models, I'm going to go through a few different scenarios here of how patients present and what we do with them. Now, this is from a laboratory's perspective. So we're looking at, cast, mounted, printed, articulated, but you can also do some of this analysis in the mouth. For instance, I mean, this patient is just has anterior contact only. This is probably a hit and slide situation. The patient probably doesn't, may have a repeated bite, but their position might change based on manipulation. So what we recommend in a case like this is a couple of things. One is, and you can perform this intraorally, this is a simple measurement that's called the Shimbashi measurement. And that is simply taking a measurement from the zenith of, say, 25 and 8 and measuring this distance in the mouth. And we're looking for 17 to 18 millimeters. Shimbashi, the person who invented this, found that through studies, the average person is somewhere between 17 and 19. And if you find that's the case in the mouth, then there's a pretty good chance we don't have to open the bite. So you can see how helpful that is, because you may want to open the bite clinically before the records come in, and this can confirm if you need to or not. Now, a case like this, there's a couple of options for confirming a bite. One is bite block, setup, try in, making sure that the bite is ideal, the teeth position are ideal. It's exactly what you would do for a partial denture. Process that in acrylic, perhaps make a scan appliance for a dual scan, and then send all the records in. That's one option. Another option that we offer, and I'm going to show that in a few slides, is called the JC Try-In, which is a fantastic prosthetic that we developed really just for chrome. We use it for other situations too, but we use it for chrome to confirm bites, to confirm opening of bites on an articulator. I'll show you some examples of that. This is a case where the patient has pretty stable occlusion, but in a Shimbashi measurement, we agreed with the doctor that the patient only has 13 millimeters. So the patient is going to be opened up 2, 3, maybe 4 millimeters, through a discussion. We will open it up on the articulator. We'll send out this try-in that's equilibrated in the mouth, and I'll show that in just a minute. But a case like this is kind of straightforward crown and bridge, dentate over dentate records, right? Mounted casts, photographs that we discussed, CT scan with the teeth apart, and then a bite. Probably in a case like this, it would just be a centric, repeatable, habitual bite. And then we make a JC try-in. Many cases are in this situation. Patient is overclosed, collapsed, and needs to be opened. Patient has some mobile teeth, which we want to know about. You can notate them when uploading the case. But this patient has 10 millimeters of shimbashi, and shimbashi isn't a black or white rule that we follow. It's just simply a tool. It's a guide. And this patient doesn't have number 8 or 9, so we kind of estimate where number 8 and 9 should be, and take the measurement, and then we have a discussion. This patient needs to be opened 6 millimeters, maybe even a little bit more, to make room for prosthetics. So there's 2 ways to accomplish that, right? Either open them on the articulator or reduce bone. But this patient probably needs a combination of both. And so what we will do is articulate with the bite that you send us, open it up on the articulator, and then we fabricate this. This is the device that we use to either confirm existing bites as it is on the articulator, or open the articulator more than 3 millimeters, fabricate a JC try-in in that position, and then send it out for try-in, for fitting and equilibration. So you can see the images here on the left, upper and lower JC try-ins. Try them in, make sure they don't rock, make sure they have a perfect fit, perfect seat, and then either equilibrate down into the proper bite, or if it's the patient's still not opened enough, you could add composite to it. You could take another bite over it if you want to do some kind of centric relation bite. But this is a great way to confirm that the arc of closure has been preserved and that the bite is accurate on the articulator. And so you would equilibrate, take a bite. Either way, you take a bite, send the JC try-ins back to us. We will re-articulate the cast, and then we move forward with the case. Just show a little.
This video will just quickly demonstrate a JC try-in. It's a double arch JC try-in. So this is a case where we want to open up the patient's bite. And the case was submitted as upper and lower cast, in occlusion, closed bite, and not overly eccentric props. Bite registration, we articulated the case, and on the articulator, we opened it up a few millimeters, and then we digitally designed 2 JC try-ins, maxillary and mandibular, assembled them, and we send them out. And when we send them out, I believe that the case was a little bit opened, and the doctor just adjusted it down. You can see there's adjustment marks here, and there's adjustment marks on the maxillary. So once the bite is equilibrated down to just where the doctor wants it, just where it's ideal in the mouth, then a bite registration is captured between the 2. Suggestion would be not to do a full arch bite, but just do sections where there's gaps, maybe one here, one here, one here, tripoding it. A full arch is acceptable, but it's just sometimes better to just put strategically placed bites so that you can see visually throughout the arch where the teeth are coming together. JC try-in.
Okay. JC try-in may also have some scan appliances. This is case-by-case basis, depending on how many teeth the patient has remaining. If the patient just has a few teeth, couple teeth, 1 tooth, and we're still making a JC try-in, because sometimes if the patient has almost no teeth, we probably want to go a different avenue, bite blocks and setups. But if we've made a JC try-in in the situation, we will probably put markers on it, and then you would do a dual scan when the patient is in. Right? The dual scan technique, just like the denture dual scan, which we'll discuss at the end with edentulous cases. So just, again, showing a shimbashi, this is 11 millimeters, and then with the appliance that you saw in the video, 17 millimeters, opens a bite. Great tool. Other common situations, class 2, class 3, severe class 3 and 2, especially class 3, we see this often. And, for these patients, we don't diagnose, we're the laboratory, but what we have seen over the years is sometimes these cases, the patient wants normal occlusion, maybe the dentist wants normal occlusion, and it might be possible, but we run into situations, as in we end up having to open the patient up maybe too much to get room for prosthetics. But we also end up with an anterior shelving of the prosthetic, because when the bone is reduced, there's going to be some bone reduction on this case. Now the bone is even further distal. And then the prosthetic has to essentially come out as a ledge to come out labially to meet the lower. And that causes problems. The lips get caught above the prosthetic. It's a food trap. It's a speech issue. Normally in these situations, if it's going to go the route of full arch restoration on implants, generally you preserve the class, and just really try to work out maybe a flat plane occlusion. Severe class 2, sometimes the same thing. So just these are considerations. You know, these are the normal records you'd send in. This patient probably has a repeatable bite, perhaps. Actually, the patient's missing an awful lot of teeth, maybe not. But anyway, often these patients should go a different route. This is probably a denture patient. This is probably an orthodontic patient, etc. Also, another case that's very common: no centric stops at all. A patient may not even have prosthetics, and in these cases, best thing to do is to send the casts in. We will just, probably not even a bite registration. We will make bite blocks, perform setups, go through just general dentistry to put teeth in the right place, in the right vertical, until you and the patient are happy. And then we use those appliances in a dual scan situation and send them in, and then we can move forward with chrome. But really need to establish a bite and tooth position on a patient like this. There is one note here. Besides the Shimbashi measurement, we also have what we call an intervestibular measurement. So if for some reason the patient is exhibiting some kind of repeatable a bite you can capture, then you can always measure from one vestibule to the other. And a good number, kind of like the Shimbashi number, a good number is about 35 millimeters. And that would be, I really have this in the posterior now, but it would be more in the anterior. All right, so, you know, somewhere here, vestibule to vestibule, 35 millimeters. Again, just another tool within a range. Another dentate situation is mobile teeth. This happens often. You know, quite often the patient doesn't have 100% mobile teeth. That there's some mobility in a lot of the teeth, but some of them are stable. This is kind of a case-by-case basis. We've seen cases where the patient, every tooth in the mouth is mobile, and then the pin guide is inserted. The pin guide actually moves the teeth into a different position. Then the implants are in a different position. It's not a good day of surgery. So there's a couple of options with these cases, but the best option is if the patient has some stable teeth and you can capture a bite, let us know what teeth are stable. The teeth that are mobile can be extracted on the day of surgery, and the pin guide can rest on those existing stable teeth. Otherwise, these cases normally go through full extraction, go to immediate dentures, stabilize the bite, and then come back later with some type of surgical guide. So that was dentate over dentate. We'll be available at the end of this whole program for questions, and I hope everyone has questions. If you're more than welcome to call in, email, have a private discussion about any of these topics anytime. But if you'd like to raise a question at the end, please do. So the next is an edentulous single arch, and we have specific records for these, the checklist: single arch, edentulous surgery with an opposing teeth or an opposing denture. So I definitely recommend printing these off. Often these are the most confusing cases, the edentulous. But let's just quickly go through the normal records. So the important notes for an edentulous case is that it's always going to be a dual scan situation. And a dual scan means you're going to scan the denture in the mouth in occlusion, and then you're going to scan the denture by itself. Those are the two scans. We do not need a scan of the patient with no appliance, unless it's going to be a totally different type of surgical guide. If it's going to be chrome or a tissue supported guide, then it has to have a dual scan. So here's the, the rules. The denture has to fit well, no movement. You can perform a hard reline. That would be ideal if the denture has any movement. Recommend not doing a soft liner, because if you do a soft liner, then we have to go a little different route with the scans. The tooth position, I put here must be ideal, but really it should be ideal because we can deviate in our planning from teeth that are not in a great position. You know, if a patient has a denture with some flared teeth or teeth that are just not ideal, at least we know where they are. We can plan for future teeth given the current tooth situation. So tooth position should be ideal, but not mandatory. And then I'll show a slide in a minute about how you can use green mousse or blue mousse if the denture does have a soft reline already in it. Occlusion is important. The pin guide is going to fit the tissue, but it's also going to fit the opposing teeth. So we want occlusion to be good and fit to be good. And then always do a dual scan with the bite, with the patient biting closed in occlusion. We don't want anything separating the denture from the opposing teeth. This is a recent development. Kind of discovered this, I think at the end of the summer, is that a doctor was testing these materials. So if you have a soft liner, you know, historically you had to take the soft liner out and do a hard reline. That's not the case now. Either use either one of these products, load the denture up with this material, and just basically perform a reline impression. And that is a radiolucent material that shows up in the CT scan. So nice trick. So single arch edentulous. So these will be essentially the records that you send in. This will be the patient scan, dual scan, bite registration, and opposing model. You can send them in digitally, but we really recommend for edentulous, just take an opposing model, take a nice bite registration between the two, and those are the only records we need. Dual scan, opposing, and a bite, and the photographs. We always need the photographs, but the records are very simple with the denture case. And this is what they should look like on the CT scanner. So this above is the denture seated. These are markers. We recommend using SureMark. You can order them from us. You can order them right from the company, suremark.com. And there's 6 markers in here. And here you see only 3, but there's also 3 on the labial buccal of the denture. So you scan the patient in occlusion with the denture seated. Then you place the denture, say, on a piece of foam or on, there's a little scan table that comes with most CT scanners, set the denture on it. And then on our end, what we see is the denture seated in the patient. We use the dots to merge the denture with the denture scan in the patient. That's how we bring the denture in, so we can see the teeth when we're planning a case. So that's a single arch. Now, double arch is a little bit different. It's actually a little bit simpler because you only scan the dentures and take photos. But you would place the markers on the upper denture, place them on the lower denture, place the dentures, both dentures in the mouth, and scan the patient, and then scan the dentures by themselves. So essentially, this is what we'll see when we print the dentures. Now, if you do not have a CT scanner that will scan from the chin to the middle of the sinus, then you would just scan the upper first and the lower first, similar to a dentate, but always in occlusion. We want to have a little bit of compression on the tissue, so you have the patient biting into it. But we want to, it's really the only way for us to verify occlusion on the double edentulous is to do a dual scan. What not to send. For an edentulous case, especially double edentulous, but edentulous case, we don't need a scan of the denture of the arch of interest because we cannot articulate it. We can't really use it at all. We can't use impressions of it. It won't help us. Just a dual scan, opposing and bite for single, and then dual scan for a double. Again, don't need these models. We do not need impressions of the edentulous arch, because when we print the denture, we're going to print it as a pin guide. We're not going to print it to do any kind of articulating. And even if we could not make the denture fit onto a tissue model. Just doesn't work. So save your stone, save your impression material. And then the last, at least in this program, the last type of case is partially edentulous, also a very common situation. And we developed this system where you don't have to go through the process of bite blocks and setups and dual scans and scan appliances, et cetera. Instead, what you'll do is you will take study models of the partial seated, and then you'll take a master cast of the patient without the partial seated. Those are the two models that we can cross mount back and forth. And you'll take a CT scan of the patient with no partial in the mouth. And this is all on that checklist. So I would highly recommend using the checklist for a partially edentulous case every time. But we can cross mount with this. So again, take a CT scan without the partial seated, unless they're flippers, which is kind of a nice thing. If you can take a flipper, the patient can seat it, you can put them in occlusion, and that is fine, even if they have metal clasps. Forgive me, CT scan out of occlusion. You can have the patient biting on cotton rolls or on the bite fork. Forgive me. Cotton rolls are better, because often if a patient has anterior teeth in a flipper, it's going to flip up in the posterior, right? So have them bite on cotton rolls. Master cast with the study model with the partial seated, and then a master cast without the partial seated. And then of course the photographs. This type of case is critical with having the retracted photographs. You can also take digital impressions of partially edentulous. So you see left to right, same patient, right? So this is a digital impression with the partial out, digital impression with the partial in, et cetera. That will help maintain the patient's bite when you're taking the bite scan while you have the partial in. As mentioned a couple times earlier, if the patient exhibits one tooth, two teeth, no stops, difficult to take a bite to establish occlusion, go through conventional workup, bite blocks, setups, try-ins, make it ideal, convert that to a scan appliance and like an all acrylic scan appliance, do a dual scan technique, send it over, and off we go. Well, these were supposed to start automatically. That's okay. So all types of situations come through our door and come through our internet provider. Just about everything you can imagine comes through for full arch cases, and we can work with really just about any situation that you send us. I think sometimes the only thing we can't do is create bone. If the patient has bone and any kind of occlusal scheme, any kind of occlusal disease, parafunction, whatever it is, we can work with it. Many thousands of cases so far. Just the last couple slides, we have this private Facebook page. It's closed only to members. This is where we post all of our updates, all of our innovations. Many surgeries are on here with voiceover tips. We have many of our customers posting cases. This site does not have vendors, does not have implant companies. It has some staff. We're happy if staff join, and doctors. So we hope you'll all join this site and follow Chrome. We post on here just about every day. Tomorrow's course will be on the pin guide and the fixation base, and those are the two first parts of a surgery. The pin guide goes in, delivers the fixation base for the bone reduction, and we'll go through that whole process tomorrow. So hope you'll join us, and I'll be happy to take some questions if anybody wants to stay on. Thank you very much for joining us today. If you have a question, you could either just type it Or you could turn your mute off and ask, but I think there's an awful lot of participants, so I think probably typing would be better. There's a question here on denture alone with foam. What is this? Okay. Whenever you do a dual scan technique, if you take the denture out of the patient's mouth and you just put it in the CT scanner, many CT scanners have a plastic chin rest or plastic plate. And if you scan the denture on that plate, the denture and the plate merge. And so essentially we end up with a denture with a plate attached to it, and we have to virtually kind of remove the two. They morph together. So instead, put a piece of foam, it can be pretty thin, you know, half an inch, quarter of an inch, on the chin rest or on the plate, then put the denture on top of that. And on our end, it appears that the denture is floating in space. And it could be right side up or upside down, doesn't matter. We can reverse it later. Any other questions? Got some thumbs up. Thank you very much. There's a question. We are recording this, and on our website, we do, on the Chrome Guided Smile website, there's a drop down for education, and there are many videos on there already. Surgeries with voiceovers. There's even, I believe there's even a course already on records, but you'll find a lot of educational videos on that site already. Do you need bite registration or cotton during edentulous scan? You always want to have the patient biting in occlusion. That's very important for edentulous scans. In fact, a lot of cases, they just stop at that point. So put the denture in the mouth, make sure it seats perfectly, make sure the occlusion is good, have the patient bite together, put them on the chin rest as opposed to the bite fork, and take the scan. There's two issues with that. One is if the denture is seated, then we can work with occlusion. Because we can turn the denture on and off, unlike dentate, we can turn it on and off within the CT scan. It's very easy for us to plan trajectory of implants and where they're going to come out in the occlusion. The other is often staff, anyone, you put the patient in the CT scan, you have them bite on the bite fork, the back of the denture tips up every time. And that's a red light. We have to get another scan. So just have the patient biting on cotton roll. I mean, bite in occlusion every single time. What are the settings for the plan mecha scan for the denture alone? Okay, that's a great question. We used to have rules for plan scan and a few other systems. They're on our website now. We have there's a page on there for the decision tree of what type of scan you take for all the different types of guides that you make. And if you have to scan with a plan mecha, I believe today you do not have to change those the MA and the KV. I believe you scan it just like a patient. You could pick, I think sometimes you pick large patient on a scan appliance, but you should not have to change the KV and the MA anymore. The only ones I see where you have to change the settings are the old Galileos, because you have to have their aluminum cylinder to scan a denture, this special device they made, and change the settings, and the old Care Streams for sure. The old before the 9100, I don't really remember the number. Maybe it was a 9000. It was the 9000 with the stitching. You have to change the KV and the MA. The JC Try-In, is there an extra charge for it, or is it part of the package? It's an extra charge because we want to a la carte it, because it's not always needed. So a JC Try-In is $125. So that send your records in. You know, part of Chrome is we include printing models, pouring models, that type of thing. So JC Try-In is $125 flat flat fee. Small VJC trying around. Oh, doctor was answering it for us. But yeah, 125. And that, thank you, Dr. Schall. If we have to put radiopaque markers, which is not often, but if the patient is mostly edentulous, we may have to put markers on it, and we charge, I think, $50 to put the markers on it. My suggestion is that you have have markers in your office. They're sure markers, order them. They're easy to use. You can actually clean them and reuse them if you want, if you really want to put holes in the denture and acrylic them in there, but keep some on hand, and then you can put them on yourself. Otherwise, order them from us. Green mousse or blue mousse can be used instead. Yes, that's right. Either green or blue. If you have a soft liner and you don't want to remove it and do a hard reline, just like in whatever slide number that was, green or blue mousse. Yes. I was not totally avoiding the question of CE credit, but if anybody watching today would like CE credit, I'm going to read off my email address, and I'd be happy to send you an evaluation, and we can do 1 hour of CE, no problem. We actually just got to about an hour right now. It's my name, ALAN, at roedentallab.com. Alan at roedentallab.com, and we will take care of CE. It'll be Ohio State Dental Board CE, which is good for most licensing out there. Can we use gutta percha points as radiopaque markers? Absolutely. That's an age-old, tried and true way to make markers. Works very well. Use the number 5, number 8 round burr, buried about 1 millimeter deep, put the gutta percha in. Just, you do it at the very beginning and do the dual scan with it. I think, a lot of times you just leave it in the denture. The denture is really has a lifespan at that point. But gutta percha, yes, 6 points randomly around the arch in the pink. You don't need to put them in the teeth, but randomly, like 3 in the palate or tongue area, and the rest out on the buccal labial. If a patient is partially edentulous and has an all acrylic partial that is fitting well, were you saying you can or cannot use that to do a dual scan radiographic markers like you did with edentulous patient? Okay, that depends on the size of the flipper. If the flipper is 3 teeth or 4 teeth, you don't need to. Take the flipper out and just do the whole. Take conventional records as if you're doing dentate. If the flipper is not holding the bite up, if it's holding the bite up, then use it as a study model. But if it is extensive, as in the flipper is half the teeth in the mouth and the bite depends on it, and it has some substance, right? It's pretty thick. I'm kind of giving you not a very good answer on the thickness of it. 2, 3 millimeter thick, has some substance, then yes, you can use that as a dual scan prosthetic. But again, if it's not holding the bite open, then just use regular dentate records. Any recommendation for scanning soft tissue with iTero? Palate is easy, but the vestibule and mandibular posterior ridge has been difficult. Now, I know that the trick, and sorry to be a little dodgy on this, but I know the trick with Trios is you use a surgical marker, like an indelible surgical marker, and you paint a grid of dots on the palate. And I think you can do that in the vestibule too, and then the scanner will pick up the dots. I don't know about that with iTero. My experience with iTero is one of the best scanners out there. It may be the patient has too much saliva, a particular patient, but iTero takes a tremendous scan. So I'm sorry to see I'm having issues with that. It really should be able to scan the vestibule. So the mousse is impressed over the soft reline material. Do not remove the soft reline. Exactly. Yeah. That's the point of it, that the soft reline can stay in and just do a wash. You want the green or blue mousse to be kind of everywhere, not to be not to be washed out. So use a fair amount of it, so you can see green or blue pretty much everywhere, and that is now your scan appliance. Yes. Should we equilibrate the bite at the time of the JC try-in? Absolutely. Thank you, Raj, for that question. Often the JC try-in goes out and it comes back and it says, good, start making chrome. Well, without any burr marks or anything or a new bite registration. Now we can trust you, you know, smiley face, we can trust you for sure. But our suggestion is finally equilibrate it until it's just right. You have blue marks, red marks all around the arch, then capture a strategic bite registration where there's gaps or three, you know, tripod the bite registration and send in the physical JC try-in with the bite registration. Will have better success. The better the bite, the better surgical experience, no doubt, every time. The blue mousse is radiopaque, yes. We can see it, and it is the brand name. You want to use green mousse or blue mousse. You can buy them from Parkel. What's the difference in indications for green mousse over blue mousse? I have no idea. In fact, when we first learned about this, we learned that it was green mousse. And then we learned from, I believe, the same person who was doing their studies on it, that it doesn't matter, blue or green, doesn't seem to make any difference. Unless somebody knows anything different out there, and I'd be happy if you typed it in right now, but my understanding is both work. With the Shimbashi measurement, are we using the CEJ as our points of reference since there can be issues with tissue overgrowth and or recession, right? Good one. And super eruption, right? Are the teeth even in the right place right now? So it's a range, it's a guide, it's a tool. I would use it at the highest part of the apex, the highest point of the CEJ, upper and lower. And again, just use it as a tool. I mean, a lot of times with these patients, you have inflammation as well, or you have severe super eruption of the lower teeth, and it can give you a false number. We've had great success with it though, and definitely use it clinically. Any other questions? Thank you all for staying on after for this Q&A. I hope to see you all tomorrow. Same Chrome time, same Chrome place. All right, thank you, everybody. Hey, and everybody be safe. Actually, we'll have a little update on our coronavirus printing. We have a whole task force here that's scouring the government and the hospitals and anywhere out there trying to give us a good direction of printing masks, printing a shield, face shield holders, these nasal applicators for testing. We have an entire room full of printers. If anybody has something that is concrete from FEMA or somebody that says, this is what you print, this is where you ship it, this is what you make, we'd love to hear from you. I know many dentists out there are in the know, you know, like a direct contact with CVC. So if you hear anything at all, please let us know. We anticipate within the week we'll be printing, hopefully on a kind of a small mid-sized laboratory mass scale of items for the coronavirus. So, okay, everybody have a nice day. See you tomorrow. Thank you again.